Hello, everyone, and thanks for joining our live event today, which is actually part of a series of live sessions that focus on the Health Financing Progress Matrix that we have launched as part of the Health Financing Progress Matrix network. And for all of you who may be joined, but also who were not able to participate in our first live session. It was about a month ago. We had a live event focused on the Health Financing Progress Matrix and health accounts. You can still listen to the recorded session in the Health Financing Progress Matrix network, where we will also be uploading the recordings of our live session today. So for some of you who might still not know me, my name is Julia Salacu, and I work with the WHO HQ in Geneva as part of the Health Systems and Governance Department. I would also like to actually welcome our speakers today, who will be presenting and reflecting on some countries' experiences where the Health Financing Progress Matrix has already been implemented. I will very quickly introduce you to the speakers and then hand over to my colleague, Matthew Jawad, for some more comments on our live session today. We will have a presentation focused on Sierra Leone from Noemi Ndao, who is a health financing specialist and currently a health advisor to the Vice President in Sierra Leone. Welcome, Noemi. We have also presenting on Sierra Leone, Dr. Michael Amara, who is actually joining us from Kenema, and she's a principal health economist at the Ministry of Health and coordinator of the Sierra Leone Health Insurance. Presenting on Bangladesh, we have our colleague from WHO country office in Bangladesh, Tauhidul Islam, who is a health financing specialist. And finally, we have Dr. Chris Atim, who, as probably most of you know, is a notable health economist with more than 25 years of experience in health systems and a leader in health financing reforms in Africa. And Dr. Atim is also a founding executive director of the African Health Economics Association. Matt, I would like to hand over to you for a quick overview on our session today. Thank you.
Great. Thanks, everyone. And hi to everyone. We're hoping Chris Atim can join. I don't see him online yet. There's a chance he might not make it, but fingers crossed, we're in touch with him. Yeah, so quickly about today's session. So as Julia said, you know, what we're just testing with this new online platform is just to kind of have some relatively short, sort of punchy conversations. This network's it's a relatively small group targeted on countries sort of really implementing the matrix. And so we put a shout out for some topics that we might discuss. And Noemi, bless her, came up with this great idea on, you know, how do we actually make impact through these reports? So of course we said, well, then you need to present on that, right? So, but you know, it is of course really important because ultimately that's the whole point of our work, right? So the matrix is, and we make no excuses, by definition, it's a very technocratic assessment, deliberately so. It's built on evidence. It's very sort of systematic. We try and we're trying to be explicit about how policy can influence health system performance, and we think this is important to have that sort of credibility and clarity and conceptual thinking and so on. That's all fine. Not that it's perfect. It can be better, but of course, ultimately, how do reports like this influence policy? It's a completely different set of considerations, or it may well be a different set of considerations that we need to think about. So a couple of last points, and then we'll hand over to the speakers. How do we even measure impact? Right? I mean, I do some thoughts on that. You know, when you do technical assistance, how do you measure the impact of that? And of course, you know, we need to think about issues like timing. Hopefully these will come out in the discussion. Timing of results, looking for windows of opportunity. I think sometimes the impact can be years later, sometimes when the political discourse and windows of opportunity open up. So those are just a few quick reflections, and I'll stop talking now and I'll hand over to our first speakers from Sierra Leone. So I'll let you introduce yourselves, Dr. Michael Amara and Noemi, and I will stop talking and try and share your slides. Over to you.
So good afternoon, everyone. It was a surprise to be asked to present on this because I actually asked a question. So I wanted to learn from other countries, but maybe we can use this opportunity to hear from you what we in Sierra Leone couldn't do better. And it helped me present, or it helped us to think about, okay, what did we learn and how could we do this differently and maybe the same way again in the next few years on how to use this matrix. So I'll start right off. You can go to next, please. Just to show you, this is the report we have. It was published in 2022 after a year of work on it. This is our UHC champion, the Honorable Vice President, who launched it, and he has been driving a lot of the health financing progress and overall kind of universal health coverage in Sierra Leone in the last 2-3 years. Next. So for us, while reflecting on how we make impact and we had impact, is really the main thing that came to mind is that the process is half of the work. So you have to choose the right people to do this. We had a group of health financing enthusiasts from Ministry of Health, from Ministry of Finance, and from partners, so WHO mainly, to come together every week, and we took our time. It took about 3 months just to go through the whole matrix, etc. But we met regularly and kept the momentum going. We fed back regularly to our bosses also in the hierarchy, so they kept being informed while not having to engage time-wise a lot, but they were abreast of what was happening, so it helped them also feel part of the process. Next, thank you. The report that we wrote after this 3 months of regular meeting, we tried to write it in a very easy to understand way. So we skipped the whole kind of, this is the situation of health financing. We jumped right into these are the results from the matrix, and this is the number of recommendations. We produced a summary that we distributed to the Ministry of Health and Ministry of Finance officials. And I think that was key also for them to read it. And I must say, we did have before that a health financing situation analysis, a health financing strategy. So there were some other documents that talked to these kind of background situations. I think where we could have done better, and that was one of the first lessons we learned, is the number of recommendations now that we produce is 49 or something, which is obviously too much. So we could have prioritize them a bit better, or like structured it differently so that it's clear for each individual stakeholder what are the recommendations targeted at them. Along the process, we made sure that the decision makers understand the concept of the matrix. So what can it do and what it can't do, and what's the principle behind. So the principle is really that we kept telling people, WHO has done the whole thinking work for us. So they have looked at all the evidence, and they have said, okay, if you do X, Y, Z, this is how you make progress, looking at all the different experience we have, etc. So we really use this to tell them, look, we're just following WHO's thinking and applying this to Sierra Leone and looking, okay, what is relevant for Sierra Leone given the stage where we are at. We looked for a champion and found it in the VP. Thankfully, it's a good thing. And he wanted to be updated also on what was happening in the Ministry of Health. And then just as you saw, we took our time. We took 3 months to develop the matrix. We took another about 6 months to write the report, and then the formatting, the review process. WHO was involved in that heavily. It all took its time. So we took a year to publish, and that was valuable also. So it's good things take its time. Then I want to talk about some of the recommendations that were taken up by leadership so far. It's not been that much time, especially for health financing. We know things are usually a bit more long-term. But we did find a complete lack of pooling and only limited strategic purchasing in Sierra Leone. The leadership has put more emphasis now, again, on this social health insurance scheme we're trying to develop. So Dr. Amra could talk more on this. He's here. You also recommended to focus more on primary care, and that led to the adjustment of the benefits package that was proposed for insurance, and also the revision of the national basic package of essential services, which is currently ongoing. Then there's no free healthcare policy, and we recommended they should develop one, and that process is now it has started. So we don't have a policy yet, but it started. Should hopefully reduce fragmentation. free healthcare in Sierra Leone is targeting children under 5, pregnant and lactating women, but there's never been any written down what's the benefits, who exactly are the target groups, etc. And other target groups have been added over the years, so it needs a policy to describe this properly. And then other things, so the matrix came and supported this whole wave of health financing interest in the country. So the health financing technical working group was revitalized. Dr. Amara is leading this. There was a health financing advisor hired for the Minister of Health and Sanitation. She's an expert also in insurance, so that's great. And then there's a health advisor to the VP who has a focus on UHC and health financing, given he's championing this. And then some things that also didn't work. Next slide. We were recommending this electronic payment expenditure tracking system. It's a public financial management tool, which we recommended to be rolled out across the ministries. It would simplify the whole budget execution a lot and lead to a much more transparency and accountability. There was a lot of internal resistance, so that wasn't taken up at all and was actually cancelled now. And then also we realized that many recommendations were kind of outside the scope of the immediate Ministry of Health. So we said the private insurance market should be better regulated, but those stakeholders were not properly engaged. And we said the tax to GDP ratio should be increased. So that also, sorry, Matt, we see your WhatsApp now. So we did say we need to make sure in the revision and in the annual review process now that those stakeholders are specifically targeted and recommendations reach them. Yes, so then what we are trying to do now is to have annual review. We will start this next month, led by Dr. Amara. So we will look at, okay, what has changed, any changes in the landscape, and then we have all the recommendations in an Excel tool, so we can look what's the progress, who's the responsible person, do we need to change this recommendation, do we need to adapt it, what's the timeline involved, are there any costs involved? So to also have more of an accountability tool for the matrix. And then based on this, we will produce some memos just for targeted stakeholders on what's the situation and what's the recommendation. So that's it from Sierra Leone side. Just the last slide is an invitation to come visit. Can't miss an opportunity. It's a beautiful place, so visit before everyone else does. The official slogan. Thank you.
Great. I mean, Julia, just before we move on to, before you introduce the next presentation, and I think we will move on pretty quickly, but I just wanted to flag that I think Sierra Leone, you're going to be the first ones to do this sort of update, right? Which, you know, the first time you do the matrix, as you said, it takes time, right? Because also people are busy doing other things. But you're kind of doing the full thing for the first time, right? But to come back to it, you know, almost like as an annual monitoring thing, hopefully, let's see, it's a relatively quick process. You're not doing the whole thing again, right? You're kind of looking at what's shifted, what's changed in the previous year. And I don't know, I would imagine something like a short 5-10 page summary document. But anyway, let's see. I think that's quite exciting that we're going to be trying, that you're going to be trying that. So back to you, Julia, and I think we move on to the next presentation now.
Thanks a lot, Noemi, for your presentation. And before we move to the next one, yeah, as Matt also mentioned, you can use the chat box for any questions, but after Bangladesh presentation, we will have also a discussion where you can do a live interaction with the presenters also. So I would like to invite our colleague from the WHO office in Bangladesh, Tauhidul Islam, who will be presenting on the health financing progress matrix in Bangladesh. Over to you, Tauhid, and yeah, we're presenting the slides also for you. Thank you.
Thank you very much. Good morning or good afternoon over here. So this is Tauhidul Islam. Basically, I work in the health financing area and supporting the government of the Bangladesh in this area. So like Bangladesh did first ever health financing progress matrix based on the first version. So and we try to use these findings to somewhat in some areas that I would like to present for you. Julia, please next. So the process is the same, but just in brief that I would like to mention that we started it 30 September in 2019 based on the first versions that like we did that we did insert thoroughly based on these questions, and we consulted with that not only the governments, also our development partners, World Bank and UNICEF. And we also presented in that high-level meetings. Eventually, that scoring basically is done by the experts for our country. And even in 2021-22, we updated some of the quantitative measures in this version. So I think you are aware of this process or this contents. Before like presenting that how we use these findings, I would like to show you the status, basically what the status of the country or why it was important and what's triggered to Bangladesh to use these findings. So that's need to be understood. Like we had a healthcare financing strategy, and that was developed back in 2012. And our target of that strategy was that reducing out-of-pocket expenditures from 64% of the total health expenditure to the 32%. But unfortunately, we saw that in 2012, 2019, the progress, basically the trend was in the reverse directions. That means out-of-pocket expenditure basically increased. So it was a real concern in the country for the policymakers and the other stakeholders, because like the newspaper medias, they focused on that issues. Eventually, if we can go to next slide, like when the Bangladesh did very good in the Millennium MDGs, but we found that in the UHC era, like one is the essential service definitely, and other is the catastrophic expenditures is increasing. So that was not a good sign and was alarming. So basically, based on that finding, so after discussing the Ministry of Health and others, so they basically organized when high-level policy dialogue, and we from WHO and World Bank partners the government to in this policy dialogue. The thing is that please, so sorry, please. Yes, please go next slide. So first of all, like whenever that's this thing, before that, what we have found, that there are many evidence, basically, whenever we tell about that health financing evidence, basically quantitative evidence we show. But in that cases, we found like it was relatively easy for the policymakers in some cases, like it provided deep insights of some of the questions or reasons behind these quantitative measures. That was, we found that useful. And that for some of us or policymakers are not much aware of that, like what is the, they cannot understand with the quantitative measure alone to identify that what is the country's status. But still there is a scoring. Since there is a scoring, so they can find the status of the country compared to the ideal situations, and they get a sense of their propositions of the country's propositions. That was one positive things that we have found. Thirdly, like yes, it was easy to grasp because the policymakers and stakeholders don't want to go through a very big document. So, and my fourth point was that like they have some questions in their mind. So since this analysis were done based on some questions and we had the answers ready. So these were the useful that we have found in this significant, in this matrix. Please, next one. So just as I mentioned earlier, first over when we produced like 13th September 2019, we completed our analysis. Then we had an opportunity in this policy dialogue to use these things. Yeah, and the Minister of Health and Family Welfare was presented over was present over there. So we try to use this health financing progress matrix finds that reasons behind this all of like quantitative measures like out of pocket expenditures, catastrophic expenditures. So what causes the inefficiency, what is the country situations in the purchasings, and that's all. And these basically the weakness of these health financing functions came out in these presentations. As Matthew said earlier, that it is not much easy to make an impact, particularly in these low-income countries and developing countries. Eventually, like some policymakers and stakeholders are not aware of the sum of issues of the health financing issues. So I won't say that like these policy dialogues, basically we made a big impact, but the thing that we found that it's a starting point, because as all of the findings we got in the one basket, so it was easy to sensitize them, and like we are still in the sensitization status to pursue the policymakers and stakeholders to take these actions and the decisions. So on this regard, on this ground, we found that it was useful that people could understand some of the things and they have started talking. And that is not the end. That was the beginning of using these things. Please, next. So therefore, like we found after following discussions of these policy dialogues that there is a problem in that also healthcare financing strategy, and it was developed back in 2012, and some issues that we need to look into that. And whenever we just advocated, not only us, like from the WHO, definitely whenever advocated and others. So from WHO, we always try to put some findings over, to take these findings from this health financing progress matrix and use it, and for this series of advocacy, then like we were like succeeded to make government agree to review this healthcare financing strategy and this thing. So we have started this reviewing of the healthcare financing strategy with the support of the WHO Bangladesh, and these health financing progress matrix findings was one, or this book is one of the key reference like reference documents that are we using on that. And eventually that in addition, I would like to say that in Bangladesh, basically this health sector program is developed like every 5 years. And the next 2023, we are going to develop a new sector program over there. And like, and still we are using these ones to get these findings and do analysis, further analysis, deep analysis, do this fifth sector program. So we can say that still we are using that for the policy advocacy, and we could make some things to make some things that we have succeeded to make policymakers understand. So these are the issues, at least diagnose the issues that need to look into, and we need to really take actions on that. Yeah, so like this way we have used and we are using these findings. But like, please, next slide, please. Next slide, please. But it's still like challenges that I would like to also mention, the challenges that we faced during the development time, and also like the others to use these findings and evidence and to translate in the policy and the actions. First of all, that for who we are working at the country office, it is difficult always to like to tell the truth always is not much easier. So we have to very diplomatic in this way. But we found that whenever we are developing the health financing progress matrix, so if we just wanted to get endorsed by the government, it might not be easy. It would take long processes, and they would like to take out all sensitive issues they can. So that was the one of the thing. So for that, we tried to show it's an independent evaluations of the WHO Bangladesh. So like we to avoid the sensitive issues. So this is the part of the development. And another thing that I would like to mention is that some of it is difficult to reach a consensus whenever we scores this scores from these findings because it's a relatively subjective. And when we got that sense, basically, we couldn't score that in the through the country consultations. Rather, we gave it to the experts, Matthew and the others. So they altogether scored that. So it was not easy for the government or stakeholders to reach a consensus scoring due to its subjectiveness. Third issues, I would like to say that's whenever we say about the using of these findings, it's not easy due to in the given political economy. That means political economy matters, and for that our there is a lot of priority, competing priority of the countries. So now this country's priority is energies or infrastructures developments. So social development has not been priority of the country. So so it is not might be easy to directly use this evidence into policy. In the Sierra Leone, we have seen that Newman showed that how the leaderships have taken. Maybe it was easier or it was taken by them, but we are trying to slowly to push the government as there is a low priority of that for the health. Another thing is that even though if there is an intentions or willingness of the government, still we got some recommendations from this health financing progress matrix in given our given our available resource and particularly we don't have much capacity yet to just move from these places where we are to go directly to the ideal situation. But still we are moving. So these challenges that we faced in our country. Next, please. Here, I would like to mention some proposed improvement for this that we have faced, but honestly that I have prepared this improvement. I feel that we had worked on this version 1. Might be at this time that some of issues have already been addressed, but during that preparing process, development and scoring process, that what we have we feel that like country of us, our health coverage only by the government is 15% and 85% health services are being provided by the private sector. So where the private sector is dominating the sector, so we need to have the policies for the private sectors, or we need to examine the policies for the private sector that that can really may impact on the system. So in that cases, we feel that if this health financing progress matrix may look more on this private sector for those countries, basically like Bangladesh, where the private sector driven, that would be useful. The second that is similar that as I earlier mentions that this scoring is a bit subjective and to be to be make it's more solid or more or near to the original or is ideal. So an independent and external review is needed. And basically for our countries, we did it at somewhat. And third point, I would like to mention that whenever we try to scoring, that we found that Bangladesh was very good in the policy processes. But whenever we feel the pulse, we feel that yes, policy process was easy. We have developed strategies and a lot of documentations, but the real problem is the implementation. So implementation might be emphasized more, and maybe it has already addressed in the versions 2 at somewhat whenever we discussed with the Matt. So from my side, so these are my presentations, and thank you for your patience. Thank you very much.
Thanks to it. That's really interesting, actually, a whole range of stuff he came up with. Just a couple of small points, because people, yeah, just to mention, I think when you did the matrix, we were using the version 1, actually, and now we're pretty systematic in doing that external review process on the scoring. We bring in 2 external reviewers because we do recognize the importance of at least building in as much quality control as you can in terms of ensuring the objectivity as far as that's possible for what's a largely qualitative assessment. So there's a whole range of ways in which you've really tried to strengthen that to prevent the undermining, if you like, of that subjective dimension. Let me hand back to Yulia. I think we're going to move, and I think Chris, our team, you've joined. I'm sorry about the connection problems, but are you there, Chris? Just to check you can hear us and we can see you.
I can hear you. But I'm really very sorry.
No problem, Chris. I actually emailed you the presentations. It's not quite the same, but maybe we'll give you a few minutes to, we'll maybe bring you in a little bit. We were just going to go to some open conversation now. I hope that's okay.
Okay, no, go, carry on. Yes.
Yeah. Yulia, over to you.
Thanks, Matt, and welcome, Dr. Atim. Thanks for joining. So yeah, it would be great if we hear from the participants some reflections, or if you have any questions from the presentations from Noemi and Tuhid. Don't be shy, or otherwise I will start calling you in. And I already have someone in mind to start with, but whoever wants to go first with some comments, feedback, or questions, please. You can just use the raise the hand function, and yeah, feel free to jump in into the discussion. Thank you, Rajesh.
Let me take it because everyone is quiet. But let me start by congratulating the two presenters. I think excellent presentations and a lot of lessons that really other countries can take forward. South Africa is kind of, planning to do the health financing performance matrix. And I think I picked up quite a few points. For instance, my first question would be to Sierra Leone and asking 49 or 40 plus recommendations. That's quite a lot. And you rightly mentioned you perhaps needed to structure it better. But how many of those recommendations did you find were already not known? Because many of the things we already know, just health financing performance matrix perhaps throws out the evidence for what we know, just to back it up for policy making. And of course, recommendations, developing recommendations is only one part of it. Important is to get at least few critical recommendations implemented somehow, and that requires engagement with key stakeholders, and many times beyond the Ministry of Health, because Ministry of Health is busy doing what they're doing, but you need to engage perhaps Treasury and in federal structures, perhaps also the provinces and provincial treasuries. So what has been the experiences around that? That would be quite interesting. And for Bangladesh, I think great presentation again, Tawheed. And what we would like to hear from you is at least 2 or 3 points or suggestions. So if a country is embarking on doing this, the second version of HFPM, what would be your, very high level but important recommendations? What factors need to be considered from the very early on phase? I saw you mentioned a few, but I would like you to reiterate them. Thank you.
Thank you very much, Rajesh. And yeah, perhaps we can start with Sierra Leone and then followed by Tawheed to answer your questions.
Thank you, Julia. I will start, and Dr. Njai wants to contribute too. He's actually also on the call. He was also part of this team. So the question about how many of these recommendations were already known. So the way we tried to do it is if something came out of the assessment that we already knew, we tried to link it with the process that's ongoing. So for one of the main one was, as I mentioned, okay, you need to pool more. Okay, the government already had this idea of Sierra Leone health insurance. So how can we use this thinking and do it better? And then target the recommendation, make it more specific. Okay, you should use social health insurance to increase the pools for XY people or to have the arrangements. So we tried to be specific, but I agree from your feedback also. I think there's a lot we can improve on in terms of how we did the recommendation, how we structured it, how many we had, and how we disseminated. I think it was just like a kind of a brain dump from our team with all the recommendation. We in hindsight now, I think we could have done this much more targeted and more precise also. And Jai, you want to add? Can you unmute yourself?
Yes, thank you, Naomi, for a wonderful presentation, and also to the Bangladesh team. Yeah, I mean, like Naomi said, initially when we had the discussions and trying to go through the math, I think one of the immediate impact was a learning process for us, because there are a lot of discussions, a lot of players, a lot of stakeholders, all of them doing different bits and pieces. There's a time we have a PVF, we have the PLK that came in, the insurance discussions are there, and all the vertical programs. So just as you would see, because of that, there are a lot of things that people that came forward as recommendations, as things that were going on. Some of them were already going, some of them were for the immediate future. So, but the matrix discussions enable us to capture all of that. And also in the description of the scheme, initially we captured like 9+, but as the discussions went on, we were able to reduce them and sort of like summarize them to fewer 3. So that's also something we've learned, as Naomi mentioned in the presentation. Initially, because of the scope, we captured a lot of issues, and then this becomes a lot of recommendations. But as the discussions have progressed from the launch of the metrics, we're able to have an summit. We've had now a technical working group on health financing, and we've had a work plan, national work plan for health financing, which has collected some of those recommendations and discussions from the summit. But what that has done is that we've been able to see the lapse with some of these things and be able to know that they connect. If we address this, I mean, it links to this, it connects to this, and that talks of the PLK being combined with the insurance scheme. So we've seen those margin and a bit of like reducing some of the fragmentations that were there, all these micro issues all over the place, and they're just focusing on what they want. This agency maybe on PBF, this agency on this agency or that. And now we're sort of tying all of those now together, and now we're saying these are the priorities. And that's reflected in the work plan that the TW for health financing is also working, because it's much more streamlined compared to the 40+ recommendations we have at the time we did the metrics discussions last year. So that's a good point. And like Naomi said, a lot of them are tied obviously to existing issues, and we're progressing towards unifying those and having things that are more impactful and as opposed to just minute. So I think that's all I want to add.
Thanks a lot, Jai and Noemi. And perhaps I would like maybe to call Tuhid for some feedback, and then Kingsley will also come in for some feedback and reflections. Thank you.
Okay, thank you, Rajesh, for your questions. If I understand properly that like in the second versions, what we would like to emphasize on or recommend the things from this health finance progress matrix, or what would be our recommendations. Now, first over, in context of the Bangladesh, I would like to say we look into the governance issues. We are not a resourceful countries, but still, I think governance issues can play role both public and the private sector. And its governance in the implementations, governance in the policy makings, and governance are monitoring these things that I would like to emphasize and will prioritize in context of the Bangladesh. Second thing is that I would say that the efficiency gain, because there is the issues that in our country around 25% of the national budget remain unspent, though we have a very limited budget. So, and it's a like finance to the line item budget to the facilities.
I think we have a technical issue. We cannot hear you. Tuhid? Or is it me?
No, I think it is. Maybe we go to Kingsley and,
Yeah,
and when to, yeah.
So, yeah, Kingsley, please. Thank you.
Thank you very much, Julia, and thanks so much for organizing this. Apologies, I joined in late. I actually didn't listen to the presentation, but I just wanted to find out from the countries in terms of the level of involvement of the Ministry of Health in rolling out the entire process, because what I've learned over the period is that the ownership of the entire process, tend to create that, what I call the needed implementation buy-in. I just want to hear from the countries what was really the involvement of the Ministry of Health, so that it doesn't really become a development partner leading this process and basically presenting the recommendations to government. Thank you.
Thanks, Kingsley. I had some issues with your connection, so I couldn't hear all your comments. But yeah, if there is also anyone else who would like to come, we have. Yeah, Njai, please go ahead.
Yes, that's a good question and a good observation. So for us, when we initialize the discussions for doing this assessment, even though yes, it started within partners, what we did was to go to the principal investigator, which was Dr. Amar, and who is the lead health financing expert at the ministry and head of the health finance, and had the discussions with him, and eventually those led to him becoming the principal investigator and lead for the assessment team. And in fact, the discussions were held at his office or his conference room. Some of them were virtual, but sometimes we go there and go to the meeting. It was very involved and contribution and giving their experience and understanding, and his team as well was very much part of it. And it was something that he was very happy with, like I said. It was also a learning process for us, because in a country that has recently become increasingly just zoom in, focus on insurance, it was good now to also maybe look at the tax, for example, and see that, okay, let's look at it from a UHC lens. Let's look at the free healthcare from a UHC lens. Oh, hang on, we don't have a policy or something that actually describes it, and and be able to look at all of these other issues with a more UHC perspective. And the team really participated, and it was really a good exercise. So since then, we've had the launch, and it has been used across the country that's been used by its team in particular. We hope obviously for more impact, for more use, but that we will continue to work on. And I think also some of the discussions and ideas we learned from this forum, from the exchanges will also help in the utilization. And as Matt mentioned earlier, also we're now discussing the review of the matrix. It's over a year now since we did the assessment here, and so he's also at the forefront of that. So we're just like, okay, you lead this, and we will support. And also now we're also trying to involve more wider stakeholders before, and with the participation of the full technical work group and other stakeholders, we're able to get more people involved than the first one, and hopefully also improve on that point that we talked about country ownership. Thank you.
You're fading away a bit there, and Jai, but yeah, I think we caught just a couple of quick reflections, and then let's see who else we can get to contribute. There's a lot of people on the call with a lot of experience in trying to engage, bring technical ideas and thinking, and we're going to ask Chris to give some of his, dare I say it, Chris, longer term reflections now on this whole sort of intersection between sort of bringing evidence to policy. But I think, we've had we had a big training event, 10 countries at the end of June in Zimbabwe, and there's one for 20 countries, Francophone, next week in Dakar. And I think we put a lot of emphasis now on that, what we call phase one, setting things up, right? I think Tuhid, when you were doing the version one, you were part of that first sort of wave of sort of pilot testing, and we learned a lot from that. And I think now we really put a lot of effort and discussion on finding those entry points. How do we, why are we doing this assessment at all? What is it going to feed into locally, and to try and get that sort of higher level buy-in and awareness, within reason before we even start, right? It's not perfect, but I think that's sort of a direction of travel. And the other thing is just to say, crafting the results and the messages is not easy. And there's a lot of sort of, I think, testing and ideas and trying out different approaches to that with countries that's currently ongoing. So I'll stop there. Anyone else want to come on? Susan, you've put something in the chat. You'd like to elaborate a little bit? I haven't had time to read it yet. So.
Sure. Hi, everyone. I'm Susan Sparks. I'm a health economist on the WHO Health Financing team, and really appreciate the reflections and the presentations. And I just put a question in because it came up, this issue about both the need to have kind of champions, but also the plethora of recommendations that come out, and also reflecting on the fact that the recommendations also target a real multitude of different types of stakeholders as well. And also we often talk about the level of policymakers, but also many of the recommendations could potentially have implications for people who are not necessarily at the policy making level, but at more of the bureaucratic technical process level. So I was wondering if either of the teams had embedded some of this thinking around the key stakeholders, not just to involve ex ante, but also that the recommendations have implications for, and if that would potentially help in some of the sequencing aspects of how those recommendations are made, in terms of both in targeting key stakeholders and different audiences, but also in terms of kind of short, medium, longer term range thinking. But really, thank you. It's fantastic to hear these. Thanks.
Thanks a lot, Susan. Also, I see that also Diane has put some comments. Diane from our WHO regional office in Afro. Diane, would you like to come in?
Good afternoon, colleagues. Just to highlight that, the engagement of the key stakeholders from the beginning is really key. As we saw on Bangladesh experience, where the uptake of recommendations, especially the political economy issues that have limited the implementation of the recommendations. I think it's important to the involvement of the key stakeholders and decision makers from the beginning. And maybe I took note of Sierra Leone's experience on the involvement of the designation of a champion. Regular feedbacks to the hierarchy it's really key, and I think it's one of the practices that can help maybe also further on the uptake of the recommendations. That's what I wanted to highlight. Thank you.
Thank you very much, Diane, for your comments. I don't know if anyone else would like to come in with some feedback or reflections. Otherwise, perhaps, Matt, we can move on with inviting Dr. Okay, I see Fadi from WHO HQ Geneva.
Yes, I have a quick question. Actually, two, but probably no quick answer. But I was wondering in these two countries how the HFPM was harmonized with other health financing assessment tools, or if there was any try to harmonize it or make sure that it was compiling results from other assessment tools, and B, how it was articulated with the health financing strategy development process. Because these two things probably goes kind of hand in hand. One is the analytical phase, while the other one is about the process of, prioritizing the 49 recommendations and bundling them, maybe identifying which one can be done within the next few years and so on and so forth. Over.
Thanks, Fadi, for your question. Sorry, I just have a very quick question from my side, Fadi, because I'm having a bit of issues with my connection. And was that a general question, or was that for one of the countries? I missed the first part.
No, for both countries.
Yes. Okay, so perhaps
maybe I could jump in just to add on that as well. Yeah, but if the other guys want to come in, and just to say, I mean, I think the matrix, and this was actually the focus of the first event we had, where we looked at what's the difference between the matrix and NHA and other assessment tools actually, and it's quite interesting to see how long it takes to implement the matrix, because it's designed to be quite let's say a relatively quick assessment, right? Unlike a sort of in-depth World Bank health financing system assessment. So it's sort of designed to be, you don't do any sort of significant primary analysis to do the matrix. It really pulls together existing information and evidence and policy statements and so on into this very sort of systematic framework. And then I was just writing in the chat, but I can say Uganda's not on the call, but they actually use the matrix formally as part of the midterm review of their current health financing strategy. And Rwanda has just agreed to do the same actually, and they've requested Dr. Parfait, their director, he basically has said that he wants a chapter in that midterm review of their health financing strategy, specifically on the results of the matrix. So let's see how this evolves, but I think that embedding and integrating is a really important development, hopefully, to get greater relevance and traction.
Thanks a lot, Matt. So I'm also mindful about the time, and perhaps we can move on and invite Dr. Atim for some.
Chris, yeah, Chris, sorry to put you on the spot here a little bit. I know you're super busy, but yeah, it'd just be really good to have some reflections from you on just this whole agenda around, obviously, the matrix is still new, but there's a lot of countries now. Just to update you quickly, there's quite a few countries that have done it. There's quite a growing number that are doing it, and an even bigger number that are planning to do it. So we're just sort of trying to think ahead, where do we go with these results, given it's a very technical assessment. But anyway, over to you, and great to see you. You're on mute there, Chris.
Yeah, sorry, yes, I was on mute. So, no, thank you very much for inviting me to this session. I browsed through quickly the slides that you sent, Bangladesh and Sierra Leone. And I just have to say, right off that the idea of the matrix, very good from the very beginning. I mean, I told you, Matt, I thought it was a very good initiative, and I'm glad to see, where it's going, in helping countries to be able to get some technical, analysis to back, policy directions that they're advocating, in particular in terms of UHC. Nowadays, that agenda, is in every country, on the agenda of every country, and there's such little technical expertise and even understanding of what is involved, that such a matrix really, really, really helps, greatly to enable countries to at least improve on the, the technical analysis and the writing, these policies. So it's, great kudos to you and all the team, for shepherding this through up to now. I mean, some quick reflections. I noticed that, the interesting variations between the two experiences that, I've just seen in the slides. And Sierra Leone, I mean, Mark Lamara and my colleagues, there's several people on this call that I recognize quite well. Michael was one of my old colleagues when I was working at the bank, we were working together, in Sierra Leone. And I remember that UHC already, the social insurance scheme that you talked about was already on the agenda even then. So, one thing I have to say, I mean, I definitely, I recognize quite a number of things that he says that really spot on in terms of identifying a champion, the process, although I would say that because there are always several institutions involved in UHC, it's not just one champion you want. You want a champion in every critical institution. Otherwise, some institutions are, up fair and, working hard, but others are not pulling their weight. Say you don't have a champion in Ministry of Finance. Basically, you are not going to get a lot of your message through, So you do need champions at different, levels, and not just, one, unless you have the miracle person who can really, who's got influence at all those levels and so on. In which case, it might be the president, for instance. Then your task is, is half done. So I agree with that, but I agree also with the main point that is the process. The process itself is, is most of the work. Getting that right, is what actually will ensure that eventually, the analysis and so forth will get a hearing and actually perhaps, the chance of being implemented. That, is experience I think I also can relate with. I think more typical though is the Bangladesh experience. I mean, for instance, I noticed that some things have been taken up, as I said, in Sierra Leone. I mean, some of the recommendations. I'm kind of struck that technical recommendations quickly taken up by the policymakers like that. It's not really typical, to be honest, in my experience. So I wonder to what extent some of those reforms were actually already, ongoing, and this technical analysis simply aligned with what was already, being planned by policymakers. So it wasn't really a heavy lift to convince them, and to what extent these were not already on the agenda, and just the analysis made them, the policymakers to see the need to, implement those reforms. I think that would be interesting, to see. And also there's a point about the free healthcare policy, and I wonder whether that is still a fragmented, policy, which is not integrated into the UHC, or to what extent can the technical analysis enable that also to become, because you're talking about fragmentation. So, obviously it's a very big fragmentation if you have a free healthcare policy that is outside of the social health insurance scheme. So, to what extent is that being influenced, the direction of that being influenced by the technical analysis. But as I was saying, the Bangladesh experience, I really resonates with me a lot because, you can do all of the analysis and you can sensitize the policymakers and so forth. The real heavy lift is the political economy aspects, the politics especially of the reform. How do you get the policymakers to actually make use of evidence in the decision making? It makes me wonder to what extent, in fact, is technical evidence a key factor in decision making on these kinds of policies, or whether there are other, criteria that actually influence policymakers more than just the technical evidence. Or, the same, another way of putting that is, what can we do to ensure that, from the very start, that we are sure that the technical analysis is going to be critical or key factor in the decision making. Obviously, it cannot be. I mean, it can never be the only factor because there are other things, there are values, and so on. that also come into play. But technical evidence should be, especially if you're seeking things like sustainability, quality of care, extended coverage and so forth. You really have to, rely on what can be brought to bear by the technical people to ensure, especially where, most countries, as we have, most of our countries in Africa, we have very low coverage, and the prospects of increasing coverage using current methods are very low. So to what extent can we bring technical evidence to bear to help policymakers to see that there are ways in which you can do that, but it requires investment, especially public funds, and proper management of those funds. Those key messages. How can we, actually make that, that heavy lift, as technicians, and taking account of the fact that the policymakers don't necessarily see these issues from the point of view of the technical matters. They are seeing the next election, how to win the next election. Basically, that's it, and whatever will help them to do that, perhaps they will do it. But if there's not, what's going to help them, the issues that have a long-term impact beyond their term of office and so forth, often don't get much of a hearing. So, this as technical people, we need to think about these aspects as well, and really try to put ourselves in their place and ask, what is it that they're looking for? How can we help them to achieve what they're looking for, even in the short term, but at the same time, how to link that with the, the longer term objectives of, these policies that will ensure that, they are not only, satisfying their immediate interests, they are also, contributing to longer term, sustainability, and other goals of these schemes that have been implemented. I think these are, questions that actually I'm putting out there. I certainly don't have any answers to them, but I'm saying these are the, the issues that come out of my experience of trying to implement these policies and, using technical evidence and so forth. So great thing to see that technical evidence is being, as it were, generated everywhere through especially this matrix format, and that some countries at least are trying to use that as a basis for making decisions. How can we make that possible for more countries so that it becomes the norm? Because I think that's a great feeling in low income countries. The use of evidence for decision making is not it's not a given. Thank you. I think I'll stop here for now.
That's great, Chris. Yeah, no, I mean, it's not easy stuff. And I guess a lot of us have been battling with these issues for all our careers, right? So it's in that sense, it's not new. And I guess it, it's as much art, right? As technical people, it's as much art as it is, right? We need to be both rigorous on the technical side, to avoid criticism and some of the issues Tuhid raised, which I think we're trying to address on. Yes, it's a
Matt. Sorry to interrupt you, Matt.
Yeah.
But now that you mentioned that we need to be rigorous, it reminds me of another challenge we do have, which is that to what extent can we, if you want to take account of the politics of the situation, you often have to sacrifice technical quality in the sense that just to quote what Obama said about Obamacare, he said that if he had to start to design the US scheme from zero, he would never have designed what he put out in place, because it's just inefficient. But it's what was possible in the circumstances, given the various interests and so on.
Yeah, sure.
The South Africans are having. The problem the South Africans have since 1994 is that there are such big interest in the private sector, which will see such a big hit from national health insurance scheme, that they are finding every means to try and delay it and prevent it and so forth. So often what will work is not necessarily what is technically the best. It is actually a compromise, that will enable the policymaker to say, yes, this satisfies our interests. This is actually very much in line with what we want, and and so forth. But it is an unsatisfactory outcome. So do we remain faithful to our intellectual integrity and say, no, this is the right thing, the best practice is this, international experience shows that, and so forth and so forth, and then let them make the choice? Or do we accept that a consensus building around what is feasible will probably sacrifice some of that technical quality? I think that's an important point also.
Yeah, No, it's a good point, and I think we whisper it very quietly, Chris, and we say that evidence can be overrated, right? but at the same time, you know, as technical agencies, we have to sort of cover ourselves to make sure that sort of technical. But of course, what you say is self-evidently true, right? So I think that's
No, thank you. Thanks so much.
Yeah, no, that's great. And Yulia, maybe back to you for any final comments. You know, we keep these conversations. We know everyone's busy and we don't drag them out too long. But maybe Yulia, maybe any final thoughts from participants, and then we can.
And also, yeah, I see that there were also a couple of questions in the chat. And actually, what I would like to point out is that these conversations and discussions don't need to stop here. I mean, it's only because we have a limited amount of time that we try to answer all questions and feedback, but we have the Health Financing Progress Matrix Network where we still can continue this kind of conversations, and we actually encourage each of you to use that. So I would like to thank all the presenters. Thanks to Noemi, thanks to Njai also for presenting on Sierra Leone. Thanks to Tuhid for joining from the Bangladesh office, and also thanks a lot to Dr. Atim for being able to join us today. Thanks also to everyone who made some interventions on the discussion and reflections. The session has been recorded, and we will put the recordings in the network. And as I said, we can continue to answer some of the questions, and we can continue the conversation in our Health Financing Progress Matrix online platform. And as I said at the beginning, this is part of a series of live events which we have kicked off, and we plan to organize other events based also on requests and how the Health Financing Progress Matrix progresses in its implementation in various countries. So with this, I would like to end the live event for today. And again, thanks for your participation. Have a good day. Bye.